Awesome. I'm supposed to wait 7 seconds on this, so hold on. 1, 2, forget it. So this whole slide, this whole talk could basically be this, all right? If you want to do same-day discharge, you don't do it in one step. You have a well-developed and mature ERAS program. It's that simple. And if you have one, you know who the key players are, whatever the fancy terms are. You know who the sticks in the mud are, the proverbial thorn in your side are. And you understand that ERAS begins in your office and goes through every single person that's involved in that person's hospital and perioperative care until they leave the hospital, and sometimes even afterwards. Once you have that built, your length of stay will go from 4 to 3 to 2 to 1, and then you realize you're keeping the patient in-house for you, not for the patient, but because you want to, and then you're ready to take the jump. So what does it look like? So I implemented ERAS in our institution in 2017. My institution is much more of a shake hands, kiss the baby kind of institution, not a committee type of institution. You may work in whichever one you work in, you know what field you play in, so make it work. It went through multiple iterations. Everyone got their input on it. Went from a 2 to 3 day length of stay to a 1 day length of stay. And in my first was in 2000. I kept them in-house from about 2018 to 2019. It was pretty routine 1 day. And then afterwards, I was like, I'm just keeping them in-house for me, not for them. So August 2019, I said, fine, let's go ahead and do it. There was no data other than our next speaker who had it out on data, and he published, and they've led the charge on this. It's phenomenal what they've done. But mine was in 2019. I think we're all about that same time here in North America. So I don't have an app. Okay, I got a cell phone, and that's what they got. They got my cell phone number, the first 10 patients. I don't have a nurse calling them afterwards. I don't have an MA checking on them. I have fellows, but they're operating. That's it. So the first 10 patients got my cell phone number on my business card. Go. I had one call me back. Post-op day 3, can't poop. Later that afternoon, she pooped. Based on that, I'm like, hey, this thing works. Cool. I even told them, you want to be a guinea pig? There's no data on this other than a group out of Europe 4 years ago. And they said, sure, why not? I feel great. I mean, they're sitting in bed like this, right? I mean, it's like, what are you going to do? And so now they get nothing different than anything else. They don't get my cell phone number. They get the answering service number. And they come and see me in 2 weeks. I tell them, go home. See me in the office in 2 weeks. They get a single sheet of paper that's double-sided that has 6 things on it. The hospital gives them this much paper. It's worthless. It's so that they don't sue the hospital. But the only thing they need to know is pain, post-op visit, activity, diet, what can I do, what can I eat? It's just 6 things. That's it. Follow-up care. So even if you build the same-day discharge program, it takes time for it to actually mature. Like, how good are you at selecting who is going to be a same-day discharge candidate? Initially, only like half of the patients that I thought were going to go. Now it's like 80 to 85% that I think are candidates preoperatively that actually go home the day of surgery. And we've kind of looked at our data, and we're all around that same rate now, where I think there's going to be about a 10 to 15% of patients who something happens in the OR. It was a hard, tough case. There was something, they woke up and they're blowing chunks because they're allergic to whatever anesthesia gas they get. But whatever it is, there's about 10 or 15% that are probably going to stay. 80, 85 is probably where we'll get to. So of the patients that I thought were candidates for going home, what were the characteristics of the ones that actually went home versus the ones that didn't go home, right? So low blood loss, short surgery, and minimal to no narcotics. So easy surgery and the blocks worked, not rocket science, right? So, and in my opinion, the most important is minimal to no narcotics. 50 to 60% of my patients get 0 narcotics for their entire hospital stay. Pre-op, post-op, intra-op, no fentanyl, they don't go home with tramadol. Only 2% of the patients go home with any type of narcotic. What may matter? If you're a man, if you don't have diabetes. What does it matter? And this is really interesting. Doesn't matter if you're 45 or you're 75. Doesn't matter your ASA. Now, given I don't have a lot of 4s, right? These are all elective outpatient colectomies that got an anastomosis. No TAMIS, no peristomal hernia repairs, no colostomy takedowns. This is just elective outpatient colectomies getting an anastomosis. Wound class doesn't matter. Doesn't matter if it's benign or malignant. You can have a colovesical fistula, colovaginal fistula. You can have terminal ileal Crohn's. And you can have a tumor. It doesn't matter. Type of surgery doesn't matter. Lefts, rights, LARs, or sigmoids. Doesn't matter. And you mature through this process. Initially, only first case of the day, I got to watch them in the hospital for 6 hours post-op. Now, anytime start. Granted, I don't typically start cases late in the afternoon. Initially, only MIS. Now, I'll do an open right and send them home. No IBD? Yeah, you can have IBD. Only gets a colectomy. Now, after talking with some people, I said, well, it didn't matter if they get a colectomy and a TURP or a colectomy and a hysterectomy. If they're candidates for discharge, they're candidates for discharge. Send them home. Initially, I'd admit them to the floor, watch them for 6 hours, get some labs, check vitals like 27 times. And now, from the OR, the nurses ask me, same-day discharge candidate? I say, sure. Send up the PACU. PACU calls me, patient looks good. You want me to send him to phase 2 or to the floor? Send him to phase 2. I'll meet him in phase 2 and talk to him for a few minutes, out the door. Initially, only good functional status, and COVID had to play in this, but now it can have less than ideal functional status, right? When the 80-year-old on 2 liters of HOMO2 doesn't want to stay in the hospital because it's a COVID surge and your hospital has 120 patients in it with COVID, you're going home from PACU. No stoma creation is what hasn't changed for me. I think if you get a stoma, you need to be educated on it. It just makes sense to me. And you have to have a good social support system. You're not going to go home and be like alone. You need to have someone that's going to watch after you. So initially it was really complicated, and now it's actually filtered down to really quite straightforward things. And you change through this process. People worry about the financial aspect of this, and there may be some validity to it, but I think the cat's out of the bag and it's going to happen regardless. So this is guarded like Fort Knox. I've tried to get it and got burned, but eventually somebody gave it to me. Probably got fired for it. About $15,000 is what it cost to do a colectomy. Most of it's direct cost, 10 to 12 is direct cost, a few indirect costs. Based on the DRG code, it's $30,000 to $40,000. I think it's $329 or $331, the DRG code, that the hospitals bill. And patient comorbidities play into it. It's about $35K. It's what the hospital gets. CPT code that you and I submit is 44204, 44205, 44207. It's the same thing. Nothing's changed. So far, over 3 years of this, I haven't had any issues with reimbursement. Looking at day 1, day 2, day 0, discharge, it's all been the same. The hospitals get the same amount of money, so they're all happy. So the process is that my office will submit the admit order just like everyone else's office does. They're supposed to be admitted, they're planned to be admitted, and then in the PACU, or on the floor depending, I evaluate the patient that day and say, do you look good? And if you look good and you feel good, go home, right? The other thing, there was a lot of talk about patient expectations and patient education regarding this. I can't emphasize that enough. Everyone knows that it starts in your office when you tell the patient, you're gonna go home the day of surgery. They go, okay, right? And then compliance with ERAS. Most of my stuff, in fact, all of my stuff, is written at a 6th grade level. And I mail it to their house. All the medicines they need pre-op and post-op are in this box that comes out of Kalamazoo, Michigan, and it's mailed to their house. Cost $80. And all the instructions are written at a 6th grade level because 50% of Americans cannot read or write at an 8th grade level. It's deplorable, but it's true. My ERAS compliance went from like 50% to 98%, right? So if you have it spelled out for patients and it's color-coded, they follow the protocol. Questions?